Very good evening, guys. Hope you're all doing well. And today we will discuss the third paper of the DNB June 2021 series. So let's get started. And this was one of the easier papers, like I would say one of the easiest papers I have solved. So I don't think you will need too much of a detailed guidance into how to write most of these answers. The ones where there was a little bit of trickiness, where you need a little help, so those I'm going to clarify. Other than that, you will see a lot of questions. Some we have discussed in some of the other papers, not very tricky. Okay, so let's get started and let's see how you manage it. So first question, this entire paper actually has two questions in one. So everywhere there are five marks into two and very few 10 mark direct questions, right? So this is a paper where time management would be difficult. You'd have to ration your time. You'll have to ration how much you write because this is one of those papers where you may just end up not completing because you have so much to write. So don't do that. See how many marks, what part, what have they really asked. Some places they have asked very precise things which are okay, but then because you would be knowing that topic so well, you would want to write too much. Okay, so let's start with the first topic, that is peritoneal tuberculosis for 5 marks and complications of stomas for 5 marks. So again, both are normal questions. So when you write about peritoneal tuberculosis, first you will write how does it happen, why does someone get it. So usually you must have seen these patients in practice. Peritoneal will be associated with GI-TB. So normally intestinal TB happens in the IC junction area, and that may also spread to peritoneum. And the risk factors are, of course, Indian population, endemic areas. So of course, India is endemic. And people who travel to endemic areas, and very important, this is a type of extrapulmonary TB. So HIV and immunosuppressed states are common risk factors. Now, how does it reach the intestine, or how does it reach the peritoneum? Normally, it will reach the GIT from a primary in the lung because of swallowing of sputum. So the primary in the lung gets reactivated when the immunity falls, and you may end up swallowing the sputum. Or consumption of unpasteurized milk may give you Mycobacterium bovis, but usually it will be sputum of Mycobacteria tuberculosis, usually from a lung primary. So first you have pulmonary TB, it gets activated. You swallow the sputum, it reaches your intestines, and normally from the intestines it will go to the visceral and then the parietal peritoneum. Normally. Rarely it can go directly hematogenously to the peritoneum as a part of miliary dissemination. That is the other way. Now you should know the gross or the types of peritoneal TB. Some of these you would have seen in real life. So you can have the ascitic type, which is also called as dry type. Then you will have the loculated ascites type, in which you get that typical doughy abdomen. When you palpate, you get that doughy abdomen feel. That is in the loculated type. There will be the there will be the adhesive type. Okay, ascitic type is the wet type, sorry. So normally when there is ascites, that will be the wet type. The adhesive type is the dry type, right? There can be purulent type and the most exaggerated type where there is adhesions and everything comes together. That is called as the cocoon type, which is a nightmare for any surgeon. That these are the five basic types of peritoneal TB: dry or adhesive, wet or ascitic, loculated, purulent, and cocoon. Okay, so these are the basic types. Now, how is the person going to present? He may have findings of tuberculosis, that is weight loss, evening fever, malaise, and all that. And initially, once it starts in the intestines, the person may have diarrhea, and typically this diarrhea is non-bloody. He will have abdominal pain, but he will have a non-bloody diarrhea. And once it reaches the peritoneum, it can cause problems like a doughy abdomen, shifting dullness, the findings of ascites, along with the intestinal TB findings. Rarely, if there is the adhesive type, it can cause small bowel obstruction. Normally, the presentation is subacute intestinal obstruction, which can rarely cause a complete obstruction, so the person will end up with acute intestinal obstruction. So most of the times, the patients will present with abdominal distension because of ascites and adhesions causing a subacute intestinal obstruction along with constitutional symptoms. So you will go about your routine investigations. The specific one, since the person may be obstructed, is going to be CCT abdomen. It may show you the lymph nodes, the ascites, all this will be seen. The matting of the bowel, omental tubercles or omental nodules. These kind of findings suggestive of a intestinal spread and the peritoneal spread of tuberculosis. If possible, you can do ascitic fluid analysis. Best thing would be to do a diagnostic laparoscopy and biopsy. And when you do a biopsy, you want to isolate the bacteria. So you will send it for culture, that is called as TB, MGIT or BACTEC. And you would also send it for CBNet or Gene Expert. That is a cartridge-based nucleic acid amplification. It's like RT-PCR. So you do two tests for isolation. One is the culture, this is liquid culture, MGIT, and other is going to be the CBNAT or RT-PCR. This will isolate the bacteria. If it's intestinal, you can do colonoscopic biopsy also. Treatment, of course, is going to be ATT, anti-tubercular therapy. Surgery is only for complications like obstruction, perforation, and so on. Otherwise, essentially, the management is going to be medical. So plain and simple, this is how you're going to tackle intestinal TB. Second question, this I have taken directly from Bailey, this little table. And since it's for 5 marks, what I suggest you to do in this is first just write the complications, like divide them. Bailey doesn't divide them. This is the table from Bailey. So I've divided them into early and late and write a few lines about them. That's it. So 9-10 complications for 5 marks with a little description is more than enough, and that's all you're going to be able to write. So there can be bleeding. If the hemostasis was not very good, that can be reactionary bleeding. Many causes of ischemia, if there was a vascularity which got twisted. So if there is a twist, so when you are pulling out the stoma, if you by a mistake alter the orientation of the bowel, if it gets twisted, so it's usually a vascular problem. There is a vascular twist. Or if there is too much traction on the mesenteric vessels, if the abdomen is very obese and very thick, and you have to forcibly pull out the stoma, in that case, if the vessels get stretched, there can be ischemia. Ischemia can lead to gangrene of the stoma. If the sutures give way, there can be a prolapse or a retraction. Right? Because most of the time, stoma patients are going to have chronic illnesses. Late, some are very common, like dermatitis. This is going to be seen in jejunostomy, where there is a lot of liquid content, or proximal ileostomies. And this is very difficult to match. But nowadays, the stoma appliances are quite good. There are a lot of barrier adhesives. With that, you can control and prevent dermatitis even in high output stomas. Of course, stoma can undergo narrowing, especially if the anatomy of the stoma is not very good. There can be parastomal hernia. Then there are those different types of parastomal hernias you should know about. And nutritional deficiencies, dehydration, if it's a high output stoma, which can be menacing to manage and cause a lot of morbidity and mortality. If you want to add a 9th point in late complication, there can be psychiatric problems. Because a lot of people are not okay with the intestinal stoma. So there can be psychiatric and social problems, which is why it is so important to help or make the patient understand how to do self-care of the stoma. If he's able to do self-care, a lot of these problems will not happen. All right, so these are plain and simple complications of intestinal stoma. Right. Another very nice question, Park's classification of fistula. So this photo is from Bailey, but I suggest you should make a much simpler diagram. This looks a little complicated. I'll make it very simple for you. You can follow as I do. So this is going to be the rectum, and where the rectum is going to terminate at the anorectal ring, this is your pelvic floor, right? Or your levator ani. So you can make simple diagram like this. So this is your rectum, anorectal ring, or levator ani, and from there starts your anal canal. And where your anal canal is going to get over, that is going to be your anal verge. And this is your perianal skin. Right? So this is your skin, perianal skin. At your anal verge, this is where the anal canal is getting open. Now the